Please start.
Yeah. Good afternoon, everyone. I'm Dr. Parag Shankar of Dekate. I'm Clinical Director of Pediatrics and Head of Pediatric Intensive Care at KIMS Kadals, Kondapur, Hyderabad. And today we are all here to go through a very interesting topic. Again, very, very important topic, identification of a shock, how to choose inotropes, something about sepsis, something about antibiotics. So I'm going to navigate you through a lot of different presentation. And at the end, if we have some questions, we will discuss about those things. So, about overview today, what we are going to talk about, what are the different pathophysiological mechanism of shock, what is a general shock management, when you call it's a fluid refractory shock, what inotropes you choose, what do you mean by catecholamine resistant shock, and something little about the respiratory support because both shock and work of breathing goes hand in hand. And we are going to go through a lot of different kind of things throughout the shock, identifying how we identify what kind of a management we do, what kind of a inotropic support we do require in this kind of a patient. So all might be aware of this called as a pediatric assessment triangle or primary assessment triangle. So what happens? This is like a visual interpretation. When the child walks into your emergency, you try to see whether this child is a stable or unstable child. So what do? You see their appearance, how they are looking. They are kind of a drowsy. They are not responding to the sounds. They are really apathetic, not moving at all. That means they are really sick. If the child is vigorous, moving along, it gives you a satisfaction the child is doing okay. Breathing, whether they are breathing faster, apneic, hypopneic, or they have any other form of different difficult breathing, you'll identify circulation if they are actually lying pale, cyanosed. So just looking at the child, you can say whether the child is kind of a stable or unstable. Once you do, here what you can say is they are stable or unstable. Once they are stable, you go to the next kind of a phase, which is called as a primary assessment, where you have airway, breathing, circulation, disability, and exposure. There are a lot of components of that. One of the case, we will see those components also. And remember, whenever you are actually trying to identify the patient's sickness at the pediatric assessment triangle, and any two of the domain are included. That means the child appearance is abnormal or child is breathing fast. So that means child is sick, critical, or unstable, life-threatening. So you have to act here itself. So stable, unstable, life-threatening, non-life-threatening. And here you get a different assessment when you go to the primary assessment. There is a work of breathing, respiratory distress, respiratory failure, compensated, non-compensated shock. So you go into the minute details of the patient sickness. Remember, unstable, life-threatening. That means any of the two things are involved, then consider that shock as a decompensated. Don't let it be. You don't have a BP apparatus there to check the blood pressure of the child, but child is looking really bad. It's drowsy as well as pale. So consider it's a decompensated shock. And the intervention should start here itself. You should not wait for any other thing. So what intervention we can do it over here? When we see a sick child, we can start oxygen, we can put an IV line, or can start a fluid bolus also. Now, management-wise, in a pediatric assessment triangle, always remember airway, breathing, circulation. So what we are going to do, assessment and intervention should go hand in hand. It's not like that I'm going to check, then I'm going to decide how this child is going to improve, then I'm going to add something. No, you have to act immediately at the point of contact. So example, in this patient is having work of breathing and shock, you start oxygen, probably non-rebreathing mask, and see how this child is doing and take a call about the next thing. So assessment and intervention should go simultaneously. So airway, you can do a little bit of a position so that the secretions has been taken care of, mouth opens up, breathing becomes fine, or you can start non-rebreathing mask. Airway protection, if they are really sick patients. So in that situation, what you can think about is, you can think about having an advanced airway. It could be a back and mask ventilation, it could be an intubation. Now, breathing, you check whether they are breathing spontaneously, they are ventilating well. That means they're just breathing jerky. That means it could be a respiratory failure. But they're breathing faster, but their ventilation, that means the chest excursion are really good. So you have a kind of some satisfaction that this child is breathing relatively okay. Circulation wise, so assessment and intervention should go hand in hand. If you take the pulse and you feel pulse is very thready, you should not be waiting for giving a fluid bolus or putting an IV line. So for IV line, what do we do? 90 second or two novel attempt. So if I'm not able to get an IV line in 90 second or two novel attempt, it is prudent to put an intraosseous and start giving fluid boluses. If you get a chance to do any investigation in this child, the most important investigation you required is a GRPS or glucose. Other investigations are complementary like culture, blood gas, CBP. So most of the time we try to take this all investigations. So if you see initial resuscitation algorithms for this kind of a child, which is given by ECCM in 2020, you can see within 1 hour of recognition of a shock and within 3 hours of recognition of shock. What is important? So septic shock is recognized as soon as possible. And what we do is definitely it is very important to understand whether this shock is related to sepsis. There are different nomenclature and definition of systemic inflammatory response syndrome, shock, septic shock, as well as severe sepsis. So what we do first is obtain intraosseous line or IV line, collect the blood cultures. If it is prudent, start one empirical antibiotics depending upon the timeline. Here, if you get a chance, you can administer the lactate, administer the fluid boluses, start vasoactive agent. So all those things are happening simultaneously. It's not like that one after another. Simultaneously, as I told you, respiratory support, depending upon the workup pattern, how much oxygen requiring, acute respiratory distress syndrome, you do it. Other allied things which is really important is, which are helpful in managing this patient is steroid in refractory shock, avoiding hypoglycemia, hypocalcemia, nutritional support. And when the shock is not collected, we're talking about a very advanced management. So it is prudent to have IV line, blood culture, antibiotics, and administration of a fluid by 1 hour, and rest of the thing by the end of 3 hours. So you see, within 1 hour, you have a lot of things to be done. So IV line, collect blood culture, start empirical antibiotics. You can have a measurement of a lactate in a blood gas, fluid bolus if shock is present, and start vasoactive agent. Here also, as we said, respiratory support is very important. Fluid and vasoactive titration and continuous reassessment. Allied therapies, which is required. So physiologically, if we talk about any shock, we should think about two: compensated and decompensated, which is basically an epidemiological definition. So what happened in a compensated shock? That I am or the patient is able to maintain the blood pressure, but other things will be there. So tachycardia will be there, low 3D pulses will be there, CFT will be prolonged, child might be drowsy, but he will maintain or she will maintain the blood pressure. In a decompensated shock, whether any feature is there or not, that means whether tachycardia is there or not, whether poor pulses are there or not, but blood pressure has to be less than fifth centile, and everybody knows what do you mean by fifth centile. Usually age, whatever 70 plus age in year into 2. So example is a 2-year-old child, 70 plus 2 into 2. So the minimum possible systolic blood pressure is 74. And this is very important. Consider shock as a decompensated unless and otherwise proved. That means any child coming to you, consider it's a, you can say decompensated shock, whether you know or not. So there are different kind of other categorization of a shock. Very, very important. Distributive shock, one of the most common shock we see in an infection in pediatric age group called as a septic shock. What do you mean by distributive shock? So what happens is what we have over here is, so we have a tank which is full of you can say blood. And what happens in a sepsis or a septic shock, you will get some kind of an inflammation. So the blood vessel will dilate. So example, I have a tank with a 5 liter of blood. Now my tank has become bigger because of the vasodilatation. Now, whatever the 5 liter of blood was already there, now it is actually relatively less for the tank. So this is called as a distributive shock. And what we see, we get a venodilatation, arterial dilatation, or vasodilatation, which is responsible for this shock. And that is the reason of a white pulse pressure. Hypovolemic shock, everybody knows you have a diarrhea, you have a bleeding. Cardiogenic shock, when my myocardium is not contracting well, the contractility is very less. Obstructive shock, when there is an obstruction for the flow of blood coming out of the right or left ventricles, preferably left ventricle. So there are different kind of a shock we see. This nomenclature is now already obsolete, but it might help you in some of the case scenarios. So you have a condition which is called as a cold shock. Cold shock means peripheries are cold. So there could be two possibilities in cold shock. Cold shock can be because my heart is not contracting well, or my systemic vascular resistance, or my blood vessels are really, really vasoconstricted. That's why there is no blood going into the circulation. So that means what is happening is my SVR is high, my blood vessels are really constricted, and my heart is also low. So what is happening here is what we are seeing is a cardiogenic shock. So why it happened? So heart is not contracting well, so there is no ejection. To counteract that, what will happen is body will try to increase the catecholamine drive. So it will constrict the blood vessel, thinking like that it might improve the blood pressure, but it is not happening. Now, second is the cardiac output is high. That means the heart is functioning really, really on the higher end of a elastance. My systemic vascular resistance is low. That means my blood vessels are bigger. So what is happening is heart is trying to catch up with that because the diastolic blood pressure depends upon the systemic vascular resistance. In that situation, what will happen? You'll have a wide pulse pressure, and this is called as a swarm shock, or sometimes mostly we call it a septic shock or a distributive shock. Now, third situation where the same patient who is coming here, septic shock, is untreated. So what will happen is my SVR will also go down slowly, slowly because already it is getting dilated. Then what will happen is my heart contractility will also go down. So my cardiac output is also low, SVR is low, and my peripheries are cold. Why peripheries are cold? My SVR is so low and my heart is very, 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 very weak. So it's not able to pump the blood. So these are the different physiological pattern of shock you'll get it. So these are the different medications available to use, and we are going to go through a case scenario also, how to choose an inotrops also. So you have a dopamine. We know that the effect, dopamine is a prodrug. So basically you have alpha and beta receptor action. Dobutamine, again, commonly used currently all over the pediatrician, but this is almost an absolute drug because again, it has a very high chronotropic agent. That means it will increase the heart rate as well as it is a dromotropic. That means it will improve the conduction. So it is a high chances of having arrhythmias. Again, it causes vasodilatation because of the beta 2 receptor rather than dobutamine. Low dose epinephrine is a better choice. So in epinephrine, you have two options: vasoconstrictor, some vasodilator. You get a vasodilator effect on the lower doses of epinephrine, which is 0.05 microgram per kilo per minute. And then you have the vasoconstrictor effect, which will give more than 0.05 microgram per kilo per minute. Norepinephrine, it doesn't have any action on the heart. It is mainly related to vasoconstriction, no action on the lungs, no action on the heart. It is just constricting the blood vessels. And you have a vasopressin. The beauty of vasopressin is it is not dependent on the catecholamine receptor, alpha or beta. It is independent of the catecholamine receptors. So when we call it a fluid refractory, so remember, whenever we are giving fluid to any patient, three things can happen. So shock and we are giving fluid. So there might be an improvement. And we'll come to know how this is an improvement. Heart rate will come down, blood pressure will improve, pulse volume will become fine, acidosis will become better, and child will start passing urine. So we are not worried about that. This is a good scenario. Here probably we'll give 20 ml or 30 ml or 40 ml and we'll stop over there because there is an improvement. But if there is no response means there is no change in the blood pressure, no change in the heart rate, pulse volume, with or without features of fluid overload. So what will happen here is there is no change in the heart rate, there is no change in the blood pressure. That means the patient is not having any response to the fluid. So you can say like that, it is a fluid refractory shock. That means there is no response of a fluid in changing the blood pressure or perfusion. Now, if we keep on giving fluid in improvement patient without understanding that fluid is improving the everything, but if you keep on giving, pushing too much fluid, what will happen? You'll start getting fluid overload. Or without that also, without improvement also, you gave some fluid to some patient, they will start having a fluid overload in the form of they might have a tachycardia, blood pressure will go down, tachypnea, oxygen requirement, saturation will go down. So all those things suggest there is a fluid overload. So whenever you are giving fluid, you can have three things. Either you can have improvement, you can have no response, or a fluid overload. So whenever we see these two scenarios, there is no response or a fluid overload, then comes the role of a inotropes. So these are the situation where we are not able to maintain the blood pressure or perfusion with appropriate fluid, or there is no response to the fluid, we think about inotropes. So now about new current guidelines, they have a differentiation where to give how much fluid. So example, just go through that. So with intensive care unit, so you are in the unit where there is an ICU, what they say is this: abnormal perfusion or with or without hypotension. That means the child comes with the prolonged CFT, pale and all those things. Those are features of, so you can give 10 to 20 ml per kilo. And another bolus we can give depending upon the situation and check the hemodynamic response. And if epinephrine, or if consider inotropes if things are not settling down with 30, 40 to 60. That means if there is no response or there is an adverse response to the fluid bolus, you consider inotropes. So with intensive care unit, you can try 10 to 20 ml per kilo, maximum 40 to 60 ml per kilo. But in a situation where there is no intensive care, what will do? Abnormal perfusion without hypotension. So there is no hypotension, don't give any fluid bolus. Keep on just giving maintenance IV fluid. But if there is a no ICU, but there is a hypotension, so you can try 10 to 20 ml. And remember, you should not give more than 40 ml per kilo. Any point of time, any feature suggestive of fluid overload, please stop the IV fluids and start inotropes. So whenever you're having a fluid refractory shock, or probably you are having a no response, then consider inotropes. Very, very important things, and everything depends upon this diagram. I would say everything in the body is about oxygen carrying capacity and cardiac output. So if you see, the oxygen carrying capacity depends upon saturation, hemoglobin, and PO2. The cardiac output depending upon where we are actually, stroke volume. So stroke volume depend upon preload to both right and left side. So preload to the right side is CVP, preload to the left side is pulmonary arterial occlusion pressure. Stroke volume, again, afterload depend upon the pulmonary vascular resistance and systemic vascular resistance. And then you have a contractility. So all these two together will decide which inotropes we should consider. And everything in the shock, even the best possible definition of a shock is basically there is a difference between the demand and supply. So the interplay between these three things, preload, afterload, which is systemic vascular resistance for the left side, and contractility will decide which inotropes to use. And we are going to talk about it. Remember, a lot of units, they follow first at epinephrine, norepinephrine, then milrinone, or dopa, dobuta, epinephrine, norepinephrine. There is no march in inotropes. We have to understand the physiology of shock and start the appropriate physiology-specific inotropes, and we'll talk about it, how to think about it, how to kind of start about it. So as we discussed, cardiac output is low. That means heart is not functioning well, or contractile is less, but SVR is high. Because SVR is high, the vessels are constricted and heart is not contracting. They will feel cold kind of thing. In this situation, what we have to use? We have to help the cardiac output. That means we have to help one, start some medication which will cause contractility of the heart, as well as it will, the systemic vascular resistance, which is actually constricted, should dilate. So inodilator. So what are the inodilators? You have milrinone, you have a low dose epinephrine 0.01 to 0.05, and sometimes people start dobutamine also. Now you have a second situation where my heart is functioning very, very fast. It's trying to cover up the diastolic blood pressure, which is very low because of the low systemic vascular resistance. So SVR is low, contractility, because it is like trying to compensate for that. So what will happen is, here my contractility is good, but my peripheries are dilated. So I have to use one medication which can cause constriction. So we have a norepinephrine, vasopressin. Both of them doesn't have any effect on the heart. Then we have a third scenario, mainly which happens in the sepsis patient, which doesn't get treated here. They come where the heart is also kind of a dysfunctional, not contracting, and my vessels, which are also getting vasoconstricted to maintain the blood pressure. So you have a medication, we have to require medications where it will, so SVR is also low here and cardiac output is low. So what we have to do is we have to give a medication which will improve the contractility as well as make the vessel constrict. So we have adrenaline and dopamine. Now, when we call it a catecholamine resistant shock, exact definition we don't know, but requiring two inotropes. So what are the catecholamines? You have adre, noradre, dopa, dobuta. So if any of them is requiring more than two inotropes in a good doses, most of the time they accept 0.05 microgram per kilo per minute, then you should consider starting steroid. So other things should be considered here is, there are a lot of literature related to that. I'm not going into detail of that. Steroid, thiamine, vitamin C, vitamin B12, these three last things corresponds, we call as a mitochondrial resuscitation. But mainly in a catecholamine resistant shock, the medication which is very important is steroid. So again, the literature says there is a weak recommendations. The dose accepted is 50 milligram per meter square per day. This is really important because the normal steroid secretions in the body is 25 milligram per meter square per day. And it came from the basic steroid requirement, as I told you. No steroid if the shock is controlled with fluids and inotropes. Yes, steroid, not controlled shock. That means you are requiring two more catecholamines. And ideally, before giving steroid, take the cortisol level, send it for that. You can give in the emergency a cortisol, hydrocortisone, and once you see the level of cortisol is appropriate, you can stop. Other thing, depending upon the respiratory pattern, you have non-rebreathing mask, nasal prong oxygen, face mask oxygen. You can actually do a primary ventilation if there is a pneumonia which is causing shock, or this patient is requiring very high inotropic support because lungs also take a significant amount of a blood supply. So if you splint the lung, probably it will help the heart to contract better. Other type of support, we have HHFNC, NIV intubations, depending upon the work of breathing and support. So if you see oxygen and ventilation, simple thing, cardiac output is defined by the cardiac entasis and physiology. Oxygen carrying capacity defined by the respiratory because depends upon the oxygenation and hemoglobin. And saturations is controlled by oxygenation and ventilation, SaO2 and PO2. These are the things which interplay between delivery of oxygen. So how respiratory support help all those hard kind of things is it improve the oxygen carrying capacity, comfort the patient, and most of this shock patient have a mild tachypnea. So it will kind of the excess burden which was there on the heart, it will take it off and it will improve the delivery. Ventilation supports a lot of, I would say, which is called as a cardiorespiratory interactions. Ventilation also spring the chest so it doesn't get collapsed. It decreases the, I would say, left ventricular afterload, support the LV. At the same point of time, it supports the RV also. If you ventilate a bad lung or a pneumonia lung with the functional residual capacity, it will reduce the pulmonary vascular resistance and help right ventricle to pump the blood. So oxygen and ventilation support, if you talk about it, is a part of a cardiac support or a part of a respiratory support. That means a patient coming with only cardiac involvement, then general support, you can give comfort oxygen, which will improve the oxygen carrying capacity. You can start NRM and decide about continuation depending upon the situation. You can give short NIV support in the primary cardiac, basically fluid related, or my heart is not contracting, what you called as a cardiac dysfunction, and intubation is required as a part of a cardiac support. Is there is a high inotropic support, and basically you see like there is a lot of blood splinting towards the lung, then you can support the respiration. But it can be a primary respiratory support also. There is a patient who is having a shock, can also have a pneumonia. So depending upon that, short-term support is required. If there is a moderate work of breathing, X-ray infiltrates are there, disease specific, and some require intubation. If they have associated very bad shock, bad pneumonia, ARDS, and cardiorespiratory failure. So what are the soft pointers which says that we are actually clinical pointers that we are dealing with the shock? So cardiac, everybody know, will be tachycardia. One of the first feature for hypovolemia is a low pulse pressure. Your pulse pressure will start going down and is commonly seen in the dengue patient. If you see dengue patient, their pulse pressure will be less. Pulse volume, blood pressure, cardio, CFT, temperature, peripheral and central temperature difference more than, I would say, 3. Respiratory tachypnea, most of these have a metabolic acidosis, so they will be more tachypnic, drowsy because less blood is going to the brain. And again, urine output is a very good marker of a prelude. Why? Because the organ which receive maximum amount of blood supply per gram of their weight, first is the adrenals and second is kidney. So if the kidney is getting a good amount of blood supply, that means my blood supply to the other organ is relatively okay, because the first place where actually we are going to do some trouble and decrease the blood flow is a kidney. So we talked about it, compensated and decompensated shock. So always consider that. Now about inotropes. So what clinically everybody says is you should consider inotropes when you are at 30 to 40 ml per kilo. Once you started using 30 ml per kilo of fluid bolus, start actually inotropes. Again, very important, physiology specific, not like an inotropic march. Initially, if you don't have a central line, you can use EJ and start giving those inotropes. High dose might require central line. Yes, you can. Commonly use our inopressor. I said ino means contracting the heart. Pressor is means compressing the blood vessels. You have dopamine, adrenaline. Inodilators, again, compressing the heart and dilating the blood vessels. You have dobutamine and milrinone. Vasopressor, only constructing the blood vessels. We have norepinephrine and vasopressor. Same diagram, which we talked about it. Very, very important. And it is an interplay between these three things: preload, afterload, and contractility. That means preload is CVP, afterload is SVR, and contractility will decide which inotropes to be used. We had this discussion again. So fluid therapy, there is a lot of discussion which one we should give it. We should give it crystalloid, 5% albumin, balance, buffered solution. So many things are there. But at this moment, the most important thing is a normal saline. And it's dictum to use normal saline unless and otherwise proved, and it is not found to be inferior to anyone. So clinical assessment after each bolus, when you are giving a fluid bolus, we should keep on monitoring this child. We should keep on monitoring this child because it is very important airway. So when we are giving a fluid bolus, you see how this child is breathing. Is there any cough? Or if the patient is kind of a ventilated or intubated, you can see how much is the tidal volume. Minute ventilations are going down. MAP is increasing. The child started coughing. There is a frothing coming into the endotracheal tube. In a breathing, you can see how this child is having a tachypnea. Grunting is there. Desaturation creeps. Their oxygen saturation is slowly going down. They are requiring more oxygen, or they are requiring a higher oxygen support. In a cardiovascular, you can actually auscultate them and say if there any gallop, tachycardia, hepatomegaly is there, hypotension is there. So all those things are really important when we are thinking about bolus. So either you can have improvement in the hemodynamics and all those things are not there, or you can have the deterioration in the form of all those kind of a feature. That means you started having fluid overload. So we talked about it, how much volume should be given. Usually with ICU, you can use up to 40 to 60 if you have an ICU. If you don't have an ICU, 30 to 40 ml per kilo. There is some concept of critical volume. It is not like that you keep on giving volume, the child will keep on improving. There is a certain volume at that point of time. Even if you push more volume, child is not going to improve. So we are going to have all those assessment throughout the things. We discussed about it. We should be very sensitive about overload, and either you have a 90 seconds or two novel attempt to put an IO line before giving any fluid bolus. Further fluid therapy in the ICU specifically, or sometimes in advanced emergency, depend upon CVP, IVC collapsibility, pulse pressure variation, echo, and we'll talk about it. Are we feeling aortic velocity? Passive leg raise agility, which was done usually possible in the adults, where what happens is we try to raise them leg and see any improvement in the blood pressure, pulse pressure, heart rate, and all those things. But in echo is very well dynamic, so we have IVC, ventricular volume, and pulse pressure variation. So this is that passive leg rising test. What happens is the semi-recumbent position, and suddenly we make them 45-degree passive leg rise. And what we do is with this, what we check any changes in the heart rate, any change in the blood pressure. If the blood pressure changes by 10 points, that means the child is responsive to the fluid, and passive leg rising test is positive, and you can consider the fluid bolus. So now this is a CVP and echo guided IVC. So what happens is you can see this patient is on dopamine. You have adrenaline. So you can see 124 heart rate and pulse. You can see 75 and 43 blood pressure. What we should do? Shall we give fluid bolus or not? So let's talk about it. So shall we give fluid bolus? My blood pressure is less in this child, which is a little bit bigger for this age. And now I do an echo and you see this IVC. You can see IVC, it's stiff. Stiff means with the breathing, inspiration, it should collapse. It's not collapsing. It is staying very kind of a thin or thick. That means there is no lack of, or there is no kind of a variability of the IVC. What it means that means my tank is full. So what it understand is that in spite of my blood pressure is less and my IVC is full, means my blood pressure is low. That doesn't mean I should give a fluid bolus. Why? Because if I give more fluid bolus, I'm going to harm this patient because my IVC is completely full. What happened here is when we put a pressure over the lever, what has happened is the CVP went from 7 to 16 and there is not much of a change in the blood pressure, and heart rate also went up. So that means CVP is not, or basically CVP is not the priority, or which is going to tell us. It might help you in monitoring, but IVC is. So in this patient, the best probable management would be starting inotropes. So non-collapsing IVC or congested IVC suggests that the fluid state is the overload side, and we should avoid giving more fluid in this patient and should consider inotropes. So now you see this. So you can see heart is functioning a little bit faster, and you can see here, this is a left ventricle, this is an aorta, and what you can see here, it is not contracting well. If you see, they are not approximating each other. So that means my heart is globular, having a lot of volume, and it is not able to eject that all volume. So probably there might be some. So that means what it suggests is either there is a ventricular dysfunction or my ventricles are so big they are adequately filled. So, and giving more fluid bolus in this patient is not going to help. So my heart is completely nicely filled. You see, you can see my heart is completely nicely filled. So probably I don't require fluid. I probably require some inotropes. My heart is nicely filled. My bag is good. So now pulse pressure variation is a new thing, which where we can identify. Pulse pressure variation is something where we can identify whether patient is going to be responsible to the fluid boluses or not. So before I play this video, you can see this is an arterial waveform. So you can see some of the arterial waveforms are kind of a longer and these are a shorter. This is called as a pulse pressure variation, and this is there is a formula of calculating it. We call P max minus P max plus P minus sorry P max and minimum divided by P average, which will tell if it is more than 13%, that means the patient is fluid responsive. So here you can see, so there are occasions where my artery line is showing there is a good amount of pulse pressure variation. So what we do in this pulse pressure variation is P max minus P minimum. P so P max is this one, P minimum is this one, and then we have a P mean. So what is a mean kind of a upstroke? So what will happen is we'll be able to calculate pulse pressure. If the pulse pressure variation is more than 13%, that means my patient is fluid responsive. I can give reasonably fluid. Same thing can be calculated. So you can see in here, you have a P max, the maximum upstroke, you have a P minimum, smaller upstroke, and you have a P mean between the two. So P max minus P minimum divided by P mean will give you pulse pressure variation. If it is more than 13%, that means the patient is fluid responsive. You can try fluid. And if it is like 5, 6, 7, that means there is no fluid, nothing to be given, and probably you manage with the inotropes. Maintenance fluids, again, the isotonic fluid is the choice, DNS, and try to maintain the, I would say, blood glucose, probably 120 to 180. Central line, it's not the must, but yes, if we are going on higher doses of inotropes, like more than 0.05, it is recommended. But nowadays, because of the EJV, you can start using these inotropes to the EJV line, and it is helping. What are the endpoints? Why we are treating this shock is we need a normal heart rate, CFT less than 2 seconds, good pulse volume, central and peripheral pulses should are well fed. This is really important. If my dorsalis pedis is palpable, that means my peripheral pulsations are good. Warm periphery, urine output, very good marker of a preload, more than 1 ml per kilo per hour. Blood pressure should go down, normalize it. Normal sensory and normal respiratory rate, these are all endpoints of treating the shock. Now about antibiotics also, when we are talking of sepsis, septic shock, we think about antibiotics is again very, very important study. So the odds of death keep on increasing. The odds of death keep on increasing if you keep on increasing the duration of antibiotics since admission. That means those who received antibiotic less than 1 hour or 1 to 2 hours have a higher chances of survival than compared to the patient who received antibiotic after 5 hours. So very, very important. Antibiotics time more like more farther you give antibiotics, higher the chances of a death. Same thing over here. So antibiotics within 1 hour, sepsis with other organ dysfunction. Again, it said within 3 hours, but try to be before 1 hour. Broad spectrum doesn't mean that you're going to start the biggest possible antibiotics. Should be physiology specific. Previous hospitalization should be considered. Rationalize the use. If the culture negative, everything is fine. Continue descent or actually come down, de-escalate, and use your antibiogram if it is available. Multi-drug therapy, yes, you can think in immunocompromised, septic shock, or high-risk patients, depending upon their condition. Here in hospital, death is less likely when you give an antibiotic within specified time, within 1 hour, as compared to more than 1 hour. So we are going to talk about some cases, how to actually consider inotropes, and then I'm going to navigate through some of the other presentations also. So 8-month-old child, previously healthy, cough, cold for 3 days, irritability since 1 day, poor feeding was there for 1 day, some suck rest cycle was present, and presented to ER in tertiary care hospital. This is the presentation. So you can see child is having work of breathing, subcostal traction, apathetic, moaning, grunting is there, highly, extremely tachycardic, tachypneic. Okay. highly tachypneic and tachycardic is there. And you can see CFT also here on the right side. CFT, you can see mottling is also there. That means there are obvious features suggestive of shock appearance and there is a perfusion related issue. So when this child came, you can see the child airway is open and stable, but child is tachypneic, saturations are low, crepitations are there. Circulation, if you see heart rate is there is a tachycardia, CFT is 4 seconds, blood pressure is on the lower side, 74/40. Peripheral pulsations are poor, skin temperature is cool, and CNS look relatively okay. So in this child, what is the possible diagnosis? Previously healthy, there is no fever, nothing. So we are dealing with something which is primarily causing the cardiac involvement. So it could be a myocarditis. And categorization of the shock, again, here the blood pressure is maintained. So if you consider there is a tachycardia, poor perfusion, but what happened is the most important thing is blood pressure is maintained. That means we are talking about a compensated shock. Now, how much fluid should be given? Are you going to give fluid or not? So very, very important things. Are we going to give a fluid or not? So let's come back to the same diagnosis or a chart what we are talking about initially. So here you just see preload, then you have afterload and contractility. As I told you, these three things are going to discuss. We are going to discuss about. Just give me 1 minute. I'm just. So what we have here is if you see preload in this child, either preload is actually normal or high because you have. So what we have over here is, sorry, I was just feeling a little thirsty. So we have a compensated shock. Why we are calling compensated shock is there is a tachycardia and the blood pressure is on the maintain. So this is a 8 months old child. So the minimum systolic blood pressure possibly is 70. So it's a compensated shock. Now whether we are going to give fluid bolus or not. So if you see history in this child, let's go back. So what has happened in this child is, so cough, cold, irritability, poor feeding. So there is a possibility that this child is little bit dehydrated. Okay, and you cannot be really dogmatic that the volume is taken care of unless and otherwise you give volume or you do an echo, and in the echo you see IVC is kind of a full, then you can say, okay, this child doesn't require more fluid bolus, but most of the time it is not available. So what will happen is here, as we discuss, we will try with 10 ml per kilo fluid bolus. So once we started 10 ml per kilo fluid bolus, what we will see? Either we will see response or deterioration or no response. So we will see whether this is overloaded or not. And depending upon the respiratory support, we started NRM, we gave IVC, sorry, NIV, HFNC, depending upon what things are required. So what happened is after giving a fluid bolus, the heart rate was remained same, but the blood pressure came down. So the blood pressure came down. That means what is exactly happening over here? That means if I give a fluid bolus, my heart is becoming weaker. So what is happening here is now the peripheries are poor. So what is happening here is just consider our contractility. Remember, the systolic blood pressure corresponds to the contractility. So my systolic blood pressure came down. That means my contractility came down. Now, what has happened to the diastolic blood pressure, which correspond to the systemic vascular resistance? Again, what has happened is it has also came down. That means my contractility is less, my SVR is also less. So which inotrops I should consider? I should consider an inotrops which is actually inotropic and vasoconstrictor. So inoconstrictor. So what are the inoconstrictors? You have dopamine or adrenaline. So what has happened in this patient? Again, I am just wanted to make the scenario differently so that you understand. What happens in our case is 30 ml per kilo fluid bolus was given. And what has happened is even after that, the blood pressure remained. Actually, blood pressure came down to 72 to 70. So we discussed one scenario over here. Second scenario we're discussing over here. So somebody gave 30 ml per kilo fluid bolus and the blood pressure came down from 70 to 40 to 70, 40. That means blood pressure came down. Heart rate little bit improved, but peripheries are still cold. So what we should do out here? So what has happened is my systolic blood pressure has came down and there is not much of an improvement even after 30 ml. That means my tank is full. So there is no further bolus which required. But what has happened is my systolic blood pressure came down. That means my inotropic effect a little bit less. That means my heart is not able to contract properly. and my peripheries are cold. In spite of a reasonable blood pressure, peripheries are cold. That means there is a possibility either my SPR is normal or high. So my contractility is normal or low, my systemic vascular resistance high or normal. So here, in this kind of a situation, what you will use? You will use a medication which will contract the heart. So inotropy and will dilate the blood vessels. Inodilator. So you have a inodilators which are available. So you can use again certainly you can use dobutamine, but main of thing is low dose epinephrine and milrinone. Now case two, we have a 10-year-old child previously healthy. He fell bound from the 10 days back, had a some limp. So basically what we're talking about, he had a cellulitis and there is a work of breathing. He came, so you have a 10-year-old child. Tachycardic is there, 124. Again, I'm not going into details. So tachypnea is there, wheezing crackles are there, but blood pressure is 80 by 40. For 10 years old, the minimum possible blood pressure systolic is 90. So there is a hypotension. So it's a compensated or decompensated. So this is a decompensated shock or hypotensive shock. So what we'll do in here? So there is no thought process over here. You will start some oxygen because this child is having work of breathing. Okay, you'll put an IV line and you'll start giving fluid boluses. So whether you have, if you have an ICU, 40 to 60, if you don't have ICU, 30 to 40. You will try to take some cultures, you give antibiotics, source control, and all those things you'll do. But what about inotropes? So I will stop this presentation and we'll talk about this case. I will project one other presentation. So be with me for a second. We are good to go. So same child, what we're talking about. So hypotension. So here we started oxygen, large bore cannula was put, investigations were sent, antibiotics was given. So in this child, what has happened is after 30 ml per kilo fluid bolus, work of breathing increased and the liver started going down. Then what is the reason for that? So once we gave a fluid bolus, what has started having work of breathing increased liver size. So that means this child started having a feature suggestive of fluid overload. So in that kind of a things, saturation started decreasing. So lungs started having kind of, I would say, flooding of the, and now what we can call is a fluid refractory shock, because after fluid there is no response, that is one thing, and after fluid there is deterioration, that means I cannot give more fluid. So if I landed up in this scenario, now heart rate is 140, still tachycardic, tachypneic, and you have a low blood pressure. So what we should do? So now again going back to the same thing, preload, afterload, and contractility. So here preload is what? So you saw that the child started having features of seepage or patients of fluid overload. So that means my tank is full or overfull. Now, second thing is contractility. So contractility corresponds to the contractility systolic blood pressure. So my 80, it is not less than the normal, which what we want is 10-year-old 90. So that means my heart contractility is less. Now what happens to the SVR? My CFT is flush. That means my systemic vascular resistance is very, very low. So SVR is very, very low. So now what medication I should use? I should use something which is actually contracting the heart. And what has happened is my vessels will get kind of which are vasodilated will get constricted. So what I will use? I know constrictor. So this is the way we would probably able to decide about which medications to be done. Now, source control has been taken care of. Hemodynamics, again, hypotension is there. Which inotropes, as we discussed, I know constrictor. So we are talking about a epinephrine. Here, epinephrine and norepinephrine was started. Steroids, again, yes, we should consider when we are on two catecholamines, the dose of a steroid, as I told you, 50 milligram per meter square per day. Yes, and there are few things I wanted to show you. One more presentation where we'll talk about it, then we'll take a questions. So one thing which I wanted to tell you is you don't need a fancy gadget when we're talking about shock, septic shock. We have had enough of episodes of Ebola and diarrhea, which we have managed without all those things. What we require, heart rate, again, you don't require fancy gadget, pulse volume, you can check with hand, blood pressure, central peripheral, urine output, sensorium, hepatomegaly, all those things doesn't require any kind of a monitoring. You know, it can be properly calculated by diaper weight. And if you ask the best other way, I want a monitor is a probably a saturation monitor. I'll keep on sharing some interesting things so that. So hemodynamic monitoring, what different things we see. We have a basic kind of a things, heart rate, blood pressure, pulse pressure variation, CFT, peripheral temperature. SLRT, straight leg raising test, we discussed 45 degrees. If the blood pressure is improving by 10 points, that means it's positive. CVP, we saw video that CVP is not a better monitoring tool unless and otherwise there is a follow-up. And we saw a child where CVP was 7 low, but IVC was full. And if we did a jugulo kind of a gastric or jugulogastric reflex, where actually I pressed on the lever and what has happened is CVP jumped up, but there is not much change in the blood pressure. Advanced IVC diameter collapsibility, we saw that. Echo, we saw that video also. Ventricular filling is really important. And pulse pressure variation. We saw this pulse pressure variation, P max minus P minimum and P mean. If it is more than 13%, that means the patients are volume sensitive. If you wanted to make it more sensitive pulse pressure variation, same thing on an intubated patient can be done during the expiration. So what happens is you can see over here, inspiration and expiration, ventilation. On expiration, it becomes really significantly important or it becomes amplified so that we can diagnose in the expiration phase of a ventilation. If we calculate pulse pressure variation and if it is more than 7%, it suggests fluid requirement. So you can see IVC over here. This is an IVC. This is an heart RA. You can see there is no variability. It's stiff throughout the breathing. It is actually same. It is not variable. It's not collapsing. Normally in the inspiration, it should collapse up to 50%. It is not happening at all. That means this patient doesn't require fluid. If you give fluid bolus, probably this patient is going to die. But that doesn't mean that every patient coming to you, you should not try. You can try 5 to 10 ml per kilo, and throughout that, you can monitor and see whether this patient is improving or not. This is another dysfunction. So now, here you can see this is an LA, this is a mitral valve, and the left ventricle. Can you see it is not contracting at all? It is just doing like this, just like this. Normally, it should actually approximate with each other, but there is not much of a contractility at all. See, it's so globular, so big, so big. That means there is an LV dysfunction. In this kind of a patient, you cannot give the fluid bolus. What you require here is a medication which is going to contract the heart or inotropic agent. Again, we discuss about choice of inotropes, but another thing to add. So cardiac output, myocardial contractions. If the myocardial contractions are low, SVR is high, then we'll require a medication which helps the heart and decrease the SVR. So inodilators. If the cardiac output is high, that means heart is functioning very kind of at the higher curve of elastance, but the SVR is low. So we are talking about a scenario where you can say a 10-year-old child having a blood pressure of 110 by 40. So what is happening is 110, which is on the higher side of the normal. And that means my contractility is really good. Systolic blood pressure corresponds to the stroke volume. So it will become, the contractility will become low and already the SVR is low. So they will hand it from warm shock to cold shock. Here we require a medication which is kind of a causing inotropy and increasing the systemic vascular resistance. So you have adrenaline and dopamine. And there are conditions where cardiac outputs are okay, but SVR is very high or cardiac outputs on the higher side. What we are talking about, we are talking about a hypertension or hypertensive emergency. What we use over is vasodilator. That's it. I think so. We can take questions. If there are any questions, we will take those questions. I would put the most important slide is this. There are a lot of other things also you should, as in preparing for the PGs or examinations, you should know about what is systemic inflammatory response syndrome, what is shock, what is septic shock. Commonly, septic shock definition everybody uses. There is a shock. So remember, if there is a sepsis, sepsis means you have a systemic inflammatory response syndrome, which criteria includes temperature, WBC count, respiratory rate, heart rate. So if you have those things with proven or suspected infection is called as a sepsis. In a sepsis, if you have a shock, it is called a septic shock. But remember, if any child coming with the shock and you give 20 ml per kilo fluid bolus and the shock becomes fine and you are thinking about a sepsis, it is not a septic shock. The septic shock definition is very clearly sepsis with shock, which is requiring more than 40 ml or more, approximately 40 ml per kilo. This is actually a definition from the past, but any child who's requiring fluid bolus is shock, most likely compensated shock depending upon the blood pressures. So at the end, you should be able to understand what are the different kind of shocks we see. So we have physiological categorization. So you have compensated, decompensated. Then you have a different kind of a pathological. We have a distributive, obstructive, hypovolemic shock or cardiogenic shock. It is very important. Then we saw how to treat this shock. What is the respiratory support we give? When we give a fluid bolus, how do we monitor them for improvement, deterioration, or no response? What is a catecholamine resistant shock? When where we consider catecholamine, when we give steroids, and the choice of inotropes depending upon the pathophysiology. So this is really important to understand the inotropes. It is really understand to choose the inotrope because there is no march. You have to use physiology specific inotropes. We'll wait for some questions if around.
Thank you, sir.